Hi, I'm Dr. Bauer. So you're probably watching this video today, probably because unfortunately, we discussed a diagnosis of prostate cancer. And so this is just a video kind of explaining a lot about prostate cancer and the various options. So I hope this is informative. Um, it's a lot of information just to talk about it. So I did have to make like a whole PowerPoint. But I'm going to try to keep it, relatively simple, I think. So let me make myself smaller. I'll be over here. All right. So what is prostate cancer? Prostate cancer is a prostate cell at some point had a genetic mutation, which happens all the time, actually, that there's an error in the way that DNA is replicated as the cells divide. And there was an error in the mechanism to stop replication. So the cells start dividing kind of uncontrollably. Um, and so you get a situation where you have a prostate nodule, and that's what's pictured here. Um, Basically, that cell has replicated a number of times, and now it's a nodule. And the way that we figure this out is we luckily have this screening test called a PSA test. A lot of cancers unfortunately don't have good screening tools. The PSA is not a perfect screening tool, but it is um, better than certainly better than nothing. It's pretty good actually in terms of sensitivity. There's room for improvement, but we definitely have been able to make a lot of use of it. And so that's what probably happened. There's other situations where prostate cancer can be discovered. I've certainly had prostate cancer discovered where the PSA was normal, and I've had prostate cancer discovered just on a routine exam where you're complaining of symptoms and the exam it shows a nodule, and then we do the biopsy and there is prostate cancer. Most prostate cancers that are discovered through screening, however, are not symptomatic, and that's great because that means we're catching them early, and that means we have all the options, more options available. The earlier we catch these cancers, the more options that are available. It's not it. You have maybe even the option to not do anything and just watch it if you catch it early, and then when you need to, you can act. And so that's why we go through all these diagnoses and biopsies and everything, even when there are no symptoms, so we can get the information and see what we need to do. We probably talked about Mr. Gleason or Dr. Gleason. And so basically, the Gleason score or the Gleason grade group is a way of measuring the severity of the cancer. So prostate cancer kind of does have a broad range in terms of severity and aggressiveness. Generally speaking, it is a slow growing cancer when you compare it to other cancers. There are variants of prostate cancer that are very aggressive, but fortunately, they're very rare. And so that's what the Gleason grade helps us sort out. And so you can see that cell there. It's not too unlike what actually you see in a under the microscope with the stains and whatnot, what the pathologist sees, and he sees the arrangement of the cells and then the cells, the way that they look and how different they look from normal. And so this Dr. Gleason came up with different patterns. And so he came up with 5 patterns. 1 and 2 are actually not cancer. So really we're talking about patterns 3, 4, and 5. And so he looked at how people did with their cancer, what pattern they have. And we know that, Gleason 3, pattern 3 is really, it's debatable as to whether or not we should even call it a cancer. It's definitely a replication of cells that's uncontrolled, but it doesn't seem to spread. It has very low likelihood of spreading outside of the pelvis. And then Gleason 4, most people will qualify, or pattern 4, most people would say that that is a real cancer. Again, it's on the slow growing end when compared to, say, pancreatic or bladder. but it's certainly a cancer. It can spread. It can be fatal over time. And then Gleason pattern 5 is extremely aggressive. That's as aggressive as any cancer. And so when you get a Gleason score, the Gleason score is the most common pattern seen under the microscope plus the second most common pattern. So like a Gleason 3 plus 4 is mostly pattern 3 and a little bit of pattern 4. And that's not as bad as a Gleason 4 plus 3, which is a little bit of pattern 3 and a lot of pattern 4. And so that's kind of confusing because they both equal 7. So there's another scale that was created called the Gleason grade group, which is probably the best way to think about it. And that goes 1 through 5. And so basically the conversion is, a Gleason 3 plus 3 is a grade group 1. A Gleason 3 plus 4 is a grade group 2. A Gleason 4 plus 3 is a grade group 3. A Gleason 4 plus 4 is grade group 4. And then if you see any pattern 5, that's considered a Gleason grade group 5. So with all that, information, you can see that there is a chance of spread depending on the type of prostate cancer. And if you did nothing at all, this is what the life expectancy would be if you did no treatment whatsoever ever. It is fatal once it spreads to lymph nodes. You have 3 years, etc. Now the medicines, even if it has spread, if you're doing the medicines, that totally changes this chart. But I put this chart on here to just have people understand, because a lot of people, I say all the time, men will lie, cheat, and steal before they let anything happen to their prostate. But this can be a serious condition. And so we did get into kind of this pattern where we weren't even checking for prostate cancer, and we were kind of telling everybody it's fine, don't worry, it's a slow growing cancer. And so this is a chart of how we've done, and you can see lately in the last few years, death from prostate cancer has started rising again. And this is because during the Obama administration, they actually said checking a PSA hurts the patient. They actually reversed that like 8 years later. But we're kind of going through the repercussions of that kind of attitude towards prostate cancer, that we don't even need to check a PSA, that we're now losing ground. So this isn't, it should be a consultation with a urologist who has expertise in the management of prostate cancer, perhaps a medical oncologist that has expertise in the management of prostate cancer could be on the team too, for sure. And if you'd like that, we have some actually great medical oncologists in the area that talk to. But it's definitely like a serious conversation. It's not just, oh, whatever. But where you fall, like I said, on the Gleason score, where you fall on this in terms of like, is this dangerous or not, is dependent on the Gleason score, your PSA blood test, and then your imaging studies and the exam. If you can feel like that, so like prostate cancer totally involving the whole prostate, that kind of increases the risk. And so literally we create a risk score. And so I include this table just because this is my job. My job is to know this information and to say, okay, you're intermediate risk, you're low risk, based on everything. And so then everything gets determined by your risk score in terms of what we should do. So I separated this PowerPoint into kind of low risk, intermediate, and high risk as one category. So low risk, one category, intermediate, high risk is a category, and then spread, if it's spread. So for low risk prostate cancer, we're really going to be talking about active surveillance. And that's basically where we watch the cancer actively. We're going to check a PSA every 6 months. We're going to check an MRI every 1 to 2 years. You're going to need a repeat biopsy within 3 years to make sure it hasn't changed. And over time, for all comers with this protocol for low risk prostate cancer, there's a 50% chance that you need to do anything ever. 50% chance you don't. So all of the treatments for prostate cancer have significant side effects. And so if you could safely not do anything, that is the best option. And with this approach, low risk prostate cancer, there was a recent study that showed actually they took all the physicians in America and had them do a survey in 1986. About 1 in 6 of them ended up getting prostate cancer, and about a third of them had low risk prostate cancer. 2/3 of them had intermediate or high risk prostate cancer. So 1/3 of all prostate cancers, we basically don't need to treat anymore, with some certain exceptions. You have a less than 2% chance of it spreading with this management strategy if you go ahead and intervene when it's time to. Now, there has been recent evidence, and I'll be asking, if you have a really strong family history of cancer, especially prostate, pancreatic, breast cancer, or ovarian cancer, that might change the calculus. Or if like the entire prostate has cancer in it, that would change the calculus. But otherwise, active surveillance is generally the way to go if you can. If you're looking at intermediate or high risk prostate cancer, however, that's when we start to talk about doing something about it. Active surveillance is an option for favorable intermediate risk prostate cancer. The chance of spread throughout the body is not 2%, though. It's higher. So that's kind of, for men in their mid to late 70s with favorable intermediate risk prostate cancer, for sure, that's an option. Watchful waiting is basically customized approach where we maybe don't do a repeat biopsy, and maybe we don't do an MRI if there's other significant medical conditions, and or you're like in your mid to late 80s, and this is like kind of almost certainly not going to be a problem long term. For most patients, though, for intermediate and high risk prostate cancer, the answer is going to be either radiation or radical prostatectomy. There is some research looking into focal treatments, which I'll talk about briefly, but generally speaking, for patients in their 50s, 60s, and 70s with intermediate or high risk prostate cancer, we're going to be looking at radical prostatectomy or radiation. So, radical prostatectomy, the standard of care is a robot. All my radical prostatectomies are done with the Da Vinci Xi. This is kind of what it looks like. That's me standing, that's not me in the picture, but that's where I sit by the console. And then over in the background, you see the surgical tech and a certified first assist at the bedside, working to do instrument changes and suction and stuff like that. This machine has no autonomous action. It doesn't do anything on its own. It simply allows me to have wristed motion in your body through small incisions. And in the deep pelvis where the prostate is, it's fantastic because the visualization is way better. You can really sew things up nicely. And it's really improved outcomes for, surgery. Actually, and this was a big debate for a long time, because basically as soon as this thing came out, everybody switched to it and they didn't even really wait for the data. We finally got the first large randomized controlled trial of open prostatectomy versus the robotic prostatectomy from Brazil 2 months ago. And of course, the results were better for the robotic patients in terms of continence and obviously blood loss, length of stay, and everything like that. So what the prostatectomy is, you can see on the left, on the top, that's your bladder. In the middle, that's the prostate. And at the bottom, that's the urethra. So in the middle slide, you can see that the prostate's been removed, which leaves a gap between the urethra and the bladder. And on the right, you can see the bladder is now sewn up to the urethra, and there's a catheter bridging it. The catheter is very important because you don't want the bladder to become distended and stretch out that very delicate area where that stitching has taken place. So there is a catheter after prostatectomy for 10 days. That's one thing to know. The other thing to know is that men walk around not leaking urine mainly because they have, this prostate is kind of blocking the urinary flow. Once this gets removed, you're dependent on your pelvic floor muscles, which men are not used to using. So there is a recovery process in terms of urinary leakage. So long-term radical prostatectomy, 95% of men after a radical prostatectomy have no significant urinary leakage 1 year out from prostatectomy, but you'll probably need to wear a Depends for 2 to 4 months once the catheter comes out. The main issue long-term with prostatectomy are erections, though. Those can be a problem. And so I do have a little bit of data on that. You may read about, if you're looking into prostatectomy, you may read about nerve sparing approach. So here's some data about the nerve sparing approach. And basically, this is out of Vanderbilt. And you can see that no matter what, you can see the blue line and the purple line. The blue line is if both nerves were spared on the right and the left. The purple line is if there were no nerves spared or one nerve spared, because they found that basically there was no statistical difference if you had one nerve or no nerve. So they just put them together. And you can see that the impact score still drops way down after a prostatectomy. And that difference between the nerve spare doesn't get you that much. As far as percentage goes, the men who need something more than a Viagra to get an erection after a non-nerve sparing prostatectomy is about 80%. The men who need more than a Viagra after a bilateral nerve sparing procedure is about 60%. So only a 20% difference, and you can see that on this graph. In addition, there's risk. So you can see that the chance of you having a positive margin, which means that you cut the prostate out, but there was prostate cancer extending up to where you cut, and potentially you left behind prostate cancer. One on the left is one statistical analysis showing a 53% increased risk of a positive margin with a nerve sparing. And then the other statistical analysis they did showed a 42% increased risk with a nerve sparing procedure. So significant increases in risk for a positive margin for a small effect. So a lot of guys who do prostatectomy will talk a lot about nerve sparing procedure and it's this panacea for erections. It is not, and it does confer some increased risk. But there are solutions to the erections after a prostatectomy. You can either do injections or the penile implant, which we can talk about. It's a same-day procedure and basically just fixes the whole problem. So that's the erection part. I did write a little letter to the Journal of Urology about this, basically with my opinion that you need to look at getting the cancer out before you go crazy saying that you're going to do a nerve spare and you should do a nerve spare in high risk prostate cancer, which is what this article was concluding, that you should do a nerve spare in high risk prostate cancer. I thought that was a little much. The other thing to know about prostatectomy, if your prostate cancer comes back, which can be anywhere between 20 to 40% chance, depending on where you are at in terms of risk. If you've had a prostatectomy, you can get salvage radiation. If you've had radiation, it is extremely dangerous to perform a prostatectomy. It's a completely different operation. You will be incontinent for the rest of your life. You probably will have an injury to your rectum, and you'll need to come out with a stool bag for 6 to 9 months. It is a horrible operation. So if you have enough life expectancy and the cancer is of enough risk where we're thinking maybe this has actually a chance of coming back, that is an advantage for prostatectomy. Now, the one caveat to this, there's a new medicine called Pluvicto, which is coming out, which we're making arrangements to be able to administer. And that is basically a find and kill. It seeks out prostate cancer cells and delivers a itty bitty tiny dose of radiation to the prostate cancer cells. And it's actually a miracle drug. It's not a cure, but for sure, as far as like the chemotherapy drugs go, it is total godsend, basically. And the role for what I'm going to use as soon as I can is to give it to people with high risk features after a prostatectomy, or to give it to patients, and then whether or not we give it to patients after radiation is less clear if it's going to be better than the current alternatives or not. But certainly after a radical prostatectomy, you can imagine if there's like one little cell that got into the lymphatics, I give this medicine, it seeks and destroys that one cell, boom. And now, you don't have to worry about salvage radiation. You can just get this medicine. There's very little side effects. Again, it's like a miracle drug. So I don't know. That's going to be in the next 5 to 10 years, really shake things up in terms of this space where you have a recurrence. So, but for now, the standard is salvage radiation. If you have a recurrence after prostatectomy, if you have a recurrence after radiation, the options are not as good. It's basically, androgen deprivation. So the other option that is endorsed by the National Comprehensive Cancer Network is radiation. Here's a radiation machine. It is very similar to a tanning booth. You go in, you go out, you're in the thing for 10 minutes and you're done. You have to do it a bunch of times though. So up front, it's super easy. It's not a major surgery. There is no hospitalization. You're in and out of the building in 10 minutes. It's just a time commitment. You have to do 5 days a week for 6 to 9 weeks, depending on what the radiation oncologist wants to do. And again, it's very similar to a tanning booth. The effects from radiation are delayed. So they begin 5 to 7 years after you have the radiation. And it can be urinary difficulty. It can be urinary leakage. It can be blood in the urine. And the erection rates go way, way down after 5 to 7 years to the point where they're equivalent to a prostatectomy after 7 years. But that is definitely an advantage of radiation. You keep your erections for at least 3 to 5 years after treatment. At 10 years out, 60% of men are requiring care for some urinary issue if they've had radiation. So it does affect the majority of men. And once these issues start, it's more of a management strategy than anything else. And so I just put in this slide to show, see the two circles. RP stands for radical prostatectomy. RT stands for radiation therapy. So for example, the unfavorable intermediate risk group, those are the options endorsed by the National Comprehensive Cancer Network. All the other options you read about are not proven to be equivalent in terms of cancer control. The two options are radiation or radical prostatectomy. That being said, rarely I will send a patient to focal therapy. And when that is basically we stick a needle in the thing. We can see it on MRI. We stick a needle in the thing and do a little frying of the thing. The problem with that is most prostate cancer, you cannot see all of it on an MRI. But the select patient, I may talk to you about it. Most patients I'm not going to talk to about this because it's an inappropriate treatment and it does not confer, it's not a guideline-based approach because it does not confer equivalent cancer control. The last thing to know, if your prostate cancer does spread or has already spread, it is not 2 years of life expectancy. It's at least 10 years of life expectancy with the current drugs. You will need lifelong androgen deprivation, but we have seen massive improvements in terms of the additional agents like Pluvicto or enzalutamide, apalutamide, abiraterone. All these drugs, 15 years ago didn't exist. Now there's like 10 different drugs that they can line up sequentially. So 10 years of life expectancy is probably underestimate. But you'll need to be getting these treatments. So that's it. And if you have any questions, just call, okay? And if you have been told you've already made your decision about radiation, then the further counseling will happen with a radiation oncologist. If you've made your decision about radical prostatectomy, please make sure to watch the radical prostatectomy video. That'll go step by step into what to expect, before surgery and after surgery. Have a wonderful day.